The meeting, how to manage lipid disorders in high-risk cardiovascular patients and how to move on. So this is a case, a 74-year-old male presenting with a STEMI that was the first diagnosis of CID, and he underwent successful primary PCI of the right coronary artery, as you can see. So, of course, he receives dual antiplatelet therapy for 12 months, and now you see the lipid panel, a very high LDL-C with 170 milligram per deciliter, the triglycerides also high, 220, and LPA 60 milligram per deciliter. And now the question is, how should we proceed regarding the LDL cholesterol? Should we start with simvastatin first and, if tolerated, switch to rosuvastatin? Or should we initially use ezetimibe and bempedoic acid to avoid the statin side effects? Or C, high-intensity statin plus ezetimibe? Or D, PCSK9 inhibitor first? Or A, none of the above? What do you think? What would who is for A? Who is for B? Who is for C? Okay, fine. Okay. D? Nobody. Okay. So that's the right answer. Thank you. We had now the focus update of the guidelines from 2019 presented on the ESC. And what is still the same is the classification for the LDL cholesterol, the target below 55 in a patient with a very high risk. And this threshold comes from the IMPROVE-IT study many years done before in ACS patient, at that time comparing simvastatin 40 plus placebo versus simvastatin 40 plus ezetimibe. And they could show, especially in the patient with a high risk, that you have a risk reduction of about 20%, and this leads to the recommendation of the 55 milligram per deciliter. And this is underlined by several mechanical studies with OCT or intracoronary ultrasound in patients with ACS treated with a PCSK9 inhibitor, reaching after 1 year very low LDL values of 24 or 28 milligram per deciliter. And what you can see that within only 1 year in this patient, you can see a reduction in the volume of the plaque, and you can also see a thickening of the fibrous cap, which I think explains the clinical data we have on these strong lipid-lowering drugs. And we have also a lot of data now from registry, for example, a very large registry from Sweden with more than 45,000 patients, showing when we have in a short time after 2 months a very low LDL, and this is sustained, that we have also a very low MACE rate in the 1 year compared to the patient who never get a drug or never reach the target of 55 milligram per deciliter. So, but the reality, at least in our country, is still different. This is a paper survey recently published from Professor Klauss from Leipzig, showing that even in cardiologists in 2024, we have only 40% of the patients reaching the target of 55 milligram. Of course, there's improvement, but it's still not sufficient from the results. And we have now these new recommendations from the guidelines that in patients with acute coronary syndromes, which are not treated before, that we have to start, or we should start, with a high-intensity statin plus ezetimibe. And there's also a very nice scheme in the guidelines showing the effect of the lipid-lowering modalities. And with high-intensity statin and ezetimibe, you can reach on average already a lowering of the LDL-C of about 60%. And in our patients, we started with rosuvastatin 40 and ezetimibe, And then after 4 weeks, we had the LDL-C of 85 already. The triglycerides were a bit lower. The patient reduced weight and so on. But we are not yet in the target. And what should we do now? And this is also mentioned now in the new guidelines that we should add, in this case, bempedoic acid. This is a substance which was shown in the so-called Klauss study 2 years ago, that in patients already for primary and secondary prevention, we could lower the LDL, and we could improve the secondary and primary secondary endpoint. And so it should be also used in a patient. So in this patient, we added then in the second step the bempedoic acid. There's only one dose of 180 milligram. And again, you can see in this scheme that when you add bempedoic acid, you can achieve LDL lowering from 40 to about 70%. And this is really a great number. So after another 4 weeks in our patient, we had now at least the LDL-C reached of 55 milligram per deciliter. And if it's not sufficient, then if it's available, of course, we have the PCSK9 inhibition, which can be added to these compounds, reaching now 80 to 90% of the LDL from the beginning. So this really good numbers, and we see that this also works in the reality. That is a study from Italy in 42 centers, only done in Italy, where they started with the PCSK9 inhibitor already at a discharge in patients with acute coronary syndromes, and you can see they reduced the mean LDL from 140 to 40 milligram at the first control, and it means a reduction of the LDL cholesterol of about 70%, and this turns over in very nice results, not only for the MACEs, but only for the mortality. So the patients who were on target had a very much lower mortality compared to the patients who were not on the target. And there are new data now for the PCSK9 inhibitor for oral compound. It was presented in last weeks in the AHA. So a new compound, 20 milligram per day, which may also reduce, like the IV compound, LDL by about 60%. So for patients who do not want to get the injections, they might have in future the option to get by tablets. And a very new interesting compound are the CEBT inhibitors that was also presented on the ESC. So CEBT transfers the cholesterol from HDL to LDL, and if you block it, then you have an increase of the HDL and a reduction of the LDL. And there was 2 studies, one in the Lancet and one in the New England Journal presented. The tandem study just compared the efficacy and the safety of this drug compared to ezetimibe and to placebo and the combination of obicetrapib. And after several weeks, you could see that you could get a further reduction of the LDL cholesterol, about 50%. These were all patients who were on to 90% on statin and had a very high risk, but did not reach the goal target of 55 with the current strategy. So this compound may be available in the second half of the next year in Europe. Now we switch lipoprotein A. Now it's also mentioned in the guidelines, levels above 550 milligrams should be considered as CV risk-enhancing factor with higher LPA levels associated with a greater increase in risk. And so I have to ask, I know my LPA, who knows the LPA? Not everybody, okay. So elevated LPA is very rare. Is it very rare? It's rare or it's not rare? It's not rare, okay. So LPA, you find it in 1 out of 5 or 1 out of 10 patients, and it has a high to very high additional cardiovascular risk. What is LPA? It is a LDA-like particle consisting of ApoB covalently bound to ApoA via a disulfide bond. And we have very good data from the Denmark group showing when you have high or very high value, that means 100 to 105 milligram per deciliter, that you have a very high risk, not only for vascular disease, but also for getting aortic valve stenosis. And importantly, it shows here the effect of increasing LPA levels and estimated baseline absolute lifetime risk for MACEs, for example. If you have a baseline risk about 5% and the LPA is very high, then it turns to a total risk of about 14% and so on and so on. So a very high LPA level increases the risk for cardiovascular disease about 3 times. So it's very important to know that. We have now LPA targeted therapies in clinical trials. We have different compound anti-size or small interfering RNA and so on. And we will expect 26 the results of the Horizon trial. It will be very interesting. And 27 Ocean and probably 28 the Acclaim trial with different compounds. And we know that with these compounds we can get down the LPA about up to 80 or 90 or even more %, but we have to wait for the clinical outcome data. Another subject is high triglycerides, and there's only now one recommendation left in the guidelines for icosapent ethyl for gram. That is the only drug which is now improved and where we have data for patients with high triglyceride, 135 to 500 milligram per deciliter. And this data come from the REDUCE-IT trial published many years ago, showing that we, over 5 years with these compounds, we could reduce the endpoints by absolutely 5%. But we had it for 1 or 2 years in Germany, but it's not anymore available in our country now. So, of course, there are always concerns regarding the statins and lipid-lowering teriparatide. So LDL might impair the cognitive function. So LDL statins might induce or worsen diabetes, or the subject issue of statin intolerance. And just to show you some slides, this shows the LDL values at birth at 30, and when you're very young, you have also very low. So the people develop, and the low LDL doesn't make any problem. The cells who need the LDL, they produce it by themselves. So you can use it for the vessels by taking the statins. The next issue was what about the diabetes? With the statins, we might see a slight increase in the HbA1c, but I think it's not clinically relevant, and we don't see it with the PCSK9 inhibitor. And another issue, what we very often see, of course, in our clinical practice, is about side effects, potential side effect of statins. There was a very great meta-analysis in 22 with more than 120,000 patients, and the bottom line is, when you have 15 patients in your office on statins and complaining of muscle symptoms, only one patient, the symptoms are really related to the statin. So there are many other reasons, people 70, 80 for muscle symptoms or joint symptoms. So we have to be very precise before we reduce or stop this kind of medication. So just to summarize how to manage the lipid disorders. Important thing from the new guidelines is in the ACS, in the high-risk patients, strike early and strong, and you should start with a combination therapy and with a high-intensity statin. If it is not efficacious and not reaching the target, then you should add bempedoic acid as a next step, and a further step, if available, is the PCSK9 inhibition. And very importantly, you should screen every patient, at least every CAD patient, for the LPA, because if LPA is high, you should further optimize all modifiable risk factors until we will have some more drugs available maybe in 2026. And CET inhibition will be another additional option in future for the patients who are already on statins and for high risk and do not reach the target. And also very important, you have to inform the patient and also the family doctor about the individual treatment targets and also about potential side effects. Thank you for your attention.